Thanks, Emily. I'm going to move fast because I know the time is limited. So what I want to do is to go a little bit beyond talk and to think about how we walk with using digital innovations, or traditionally called health informatics, in terms of understanding how to evaluate, understand children better, get hold of vulnerable populations, and essentially see if we can actually enhance our approaches to tackling difficult problems that we see in the clinic. Okay, so what do we want to do? I'm going to give you 3 worked examples of how we're currently at the Maudsley using innovations within digital health. So first thing is to make better use of existing information. We now are able to implement relatively recent innovations in computational power and computational linguistics to capture who is coming through our services, what symptoms they're presenting with, and what our outcomes are. We're quite interested, obviously, in improving our ability to get at data that we think is valuable to making clinical decisions. And we haven't done a lot of that yet, so things like patient-reported outcomes, how do we get a better handle, how do we get that information into clinical services for evaluation? I'm going to touch on that. And then finally, which is the least mature but maybe the most exciting, is how do we take advantage of recent innovations within wearable technology to manage children with ADHD. Okay, so I'll crack on. As you will know, we have an interesting system here that essentially is a governance model for running case note reviews and research using our electronic health record system. We're not alone now. There's 12 other trusts that have CRIS in their working alongside their healthcare record systems, and that provides us with huge amounts of information. So we have 40,000 children currently that have a CRIS record. That is millions and millions of documents, far beyond anything you could really tackle with a group of researchers just filtering through notes. It's structured fields, but the most of the data is held within the free text fields, and that's where we can actually start to use some software to be able to understand it better. The CRIS system anonymizes it, so it enables us to actually use research which is palatable to the clinicians, the children and the young people that we see. And that's enabled us to do several things. These are just some of the examples that I've used it for. So one is the surveillance of use of off-label medication in certain groups. Now, this group here had 3,500 children. I couldn't have been able to do that without using natural language processes to get at that outcome. The other approach is to have a look at what's happening in terms of important symptoms. These are things that are not commonly captured within structured data, so we're using machine learning processes to hoover up the data that relates to suicidality and 3,500 children with autism. Again, about 500,000 records we had to process. And also it's giving us an understanding of who is not doing so well under conventional treatment. So this is processes that we used to look at comorbidity. Because we have a massive data set, we are actually able to try and look at rarer comorbidities or rarer populations and understand how well antipsychotics are treating children with early onset psychosis, and then also use machine learning approaches to pull out symptoms to understand what the symptom profiles don't seem to be responding as well as we'd like to antipsychotic medication. Okay, so that's very nice. That sort of tells us a little bit about how we're doing with the population that we're seeing in our clinics. But what we really want to also understand is how well we're serving the population that our clinical services cover. Now, England is pretty good at collecting information. We're quite a bureaucratic group. What we're not very good is sharing that information between different systems. So we have routinely collected nationally large amounts of information, in fact entire censuses of young people through our National Pupil Database. That records every child that's attended school since 1997 and tracks them longitudinally as they attend school, what their attainments are like, what social services involvement is, etc. We have systems like CRIS. We have a national measurement program in terms of height and weight. And also, as Ben has mentioned, we have our healthcare system, our acute healthcare system through the hospital episode statistics. So, what we've done recently is link some of that data together. And that's provided us with this understanding of what is our population that we serve and who is coming in to clinic and what their outcomes are. So we're able to capture about 180,000 children that are resident within the boroughs, understand which of those are actually coming into our services, and then having a look at what their outcomes are. So this is just a worked example. This is looking at all children that have attended to accident emergency in the last, between 2009 and March 2013. The plot on the right shows you, so we've got the population prevalence in the school, so we've got a good denominator, and then we're trying to understand who comes to services. The little blobs here give us an indication of which schools, so the rates within schools. So the higher, these little blobs up here, are schools with higher rates of self-harm presentation in the population. At the bottom, they are lower. And then we're able to capture these large populations and understand from a population perspective, so from what's been collected through the school census data, about who is more likely to attend with an episode of self-harm. And this is research that's ongoing and that's been supported by the MQ research group. So what it essentially has enabled us to do to pull out fairly rare population, things that we didn't really know about. For example, we're seeing much greater rates of young people, male young people with autism that are presenting. These aren't autistic children that are in our services. These are autistic children that are recognised by the educational system. We know that less than 80% of the children that are attending school are much more likely to present with self-harm, which is quite a novel finding. We also know, looking forward, that children with hyperactivity and also looked after children are presenting much more in the future with self-harm to our accident emergency services. So that's quite a good way of trying to understand population need and the gaps and the areas that we need to tackle. I'm very pleased that a lot of this work is being continued by other research groups, other research funds, to actually unpack why, things like social contagion, etc. Okay, so the second aspect of this work, I've just got a little bit of time, is how do we get better at capturing information that is that we should be getting within our clinical services. So one particular thing that we're interested in is capturing patient-reported outcomes, and this is a system that we developed which is collecting the Strengths and Difficulties questionnaire, which really every child should have captured when they attend services at baseline and at follow-up. And we've got a system now that hoovers information from the clinical record, identifies those that should have an STQ completed, creates a schedule, texts them, and emails them to ask them to complete it through an online portal. And this is the system that we've developed. Importantly, it sits within SLAM IT systems, and I think that's crucial. There are lots and lots of portals that are essentially available for putting in data, but it doesn't nest within our clinical systems. So this is our online questionnaire method, which you can complete online. So the caregivers get a prompt. And this is something that we're looking to deploy quite, we hope, within the next few weeks within Lewisham services, within the NTT service. And also it allows us ways of better collecting information, because if you don't have an SDQ complete in some areas, sometimes that reduces the use of those particular outcomes. Other things that we can do, which are useful, is be able to say, would you like to would you like to be contacted by a researcher for a particular research program? So we have these as features that we still need to get ethics for, but we're actually able to capture the population and ask them through online systems and prompt them to see if they're interested in research. Importantly, we're able to give feedback about what they've done in terms of their completion. So this is just a list of and progress over time. So this is really trying to enhance the data that we should be collecting using digital methods rather than traditional paper methods at improving our understanding of clinical care. Okay, this is me, sorry, this is my phone, but this is me giving trying to make it more convenient, because when we do audits of our clinical records, we're pretty dreadful at actually completing these outcome measures. So from the 36,000 children that have been have an accepted referral, we only get 12,500 in terms of having baseline SDQ, and we only get 1,500 that have a follow-up SDQ within 6 months. So we're not doing very well using current methods. I'm hoping this will reduce the clinician burden and actually improve our understanding of how well we're providing healthcare. Okay, so fine, that's good. That's collecting things that we should really be collecting and then using digital systems to enhance that. How do we then use our current innovations to improve decisions that are made in the clinic? So, as a case example, and this is supporting me, this funding from the Psychiatric Research Trust is funding me to having a look at how well we can apply wearable devices to understand hyperactivity and other profiles in real-world settings. So we prescribe quite a lot of medication, no more than other groups, I have to add, but we see quite a lot of people, so we see hundreds of children each year that have with ADHD. We make that diagnosis, and we, nearly 50% of that group will go on to receive medication. What we're not very good at is actually really tracking the progress of individuals in real-world settings, so in home, in school, and seeing how well they respond to medications as we titrate them. We just don't have the clinical services to really evaluate routinely and systematically how well children are doing. Now, in trials, and this has been going on for quite a long time, they often use objective measurements through accelerometry. So they've, this is Jim Swanson, this is years and years ago, but he used these very big, and I think Eric Taylor has done the same, used very big, bulky devices to really get accurate tracking of how kids are doing in terms of hyperactivity. So he's not taking anything new, not proposing to do anything new. It's been done in trial settings. And what Jim Swanson has worked out is that it's important to actually track them, understand what the context of the situation they're in order to get discrepancy in terms of symptom discrepancy. So this is looking at kids in seated task times. And what you see is separation, really, during the seated task time between those who were treated with medication and those that are on placebo. So it's during the classroom activity, that's when you start to see discrepancies. And now, fortunately, we can now start to do that on the cheap. So, and we don't have to slow the kids down with these great big, well, maybe it's useful to slow them down, but we don't need to use these very big, bulky devices. So I've been working with a group in Czechoslovakia, as it happens, that have managed to produce a very, very cheap but accurate wearable device that can be used in children, and we can get we can get measures of their overactivity within the school day. And we can use that, so essentially a child can come to clinic, they can wear the watch for several weeks, and as we titrate the medication, we can get a better understanding and objective measurement of what's happening. And this is synthetic data. Well, actually, this is my data. This is me on a busy day and on a less busy day. But essentially, the idea is that we can create these systems. I've got 1 minute. We've got to create systems where we can see where the effects potentially, where we can see hyperactivity being dampened down, and we can do that fairly accurately within each day, so we can see when we should start giving top-up medication, etc. And then have a look at the effects. So we just get a better sense of what we're doing. Okay, I'm going to leave it there. I think I've raced through that, but I'm very grateful for all this. So just to also say that this is team science. It is very much part of informatics. You can't have anyone does it by themselves. So this is a huge group that have supported me in this work. So thank you to them.